Good afternoon, everybody. It's a very nice day today to meet again in our continuous activities between the Afro-Asian Council of Ophthalmology and China and the Egyptian Ophthalmological Society. All my thanks to the very active Professor Dr. Lezing Wu, the president of the Afro-Asian Council of Ophthalmology, for his honorable invitation for our second Afro-Asian Council on Ophthalmology online lectures and third with Chinese ophthalmologists. During the COVID-19 time, without seeing each other face-to-face, this was the first time. This was with the Afro-Asian Council of Ophthalmology, and today we are sharing with you this to go through our activities before of scientific cooperation. As we can see in Yinchuan 2015, then Lishan in 17, same year in Chengdu, and ended with Guangzhou. Then in 18, we have met with the Chinese Ophthalmological Society in Hangzhou. And in Shenzhen, 2019 was our last year to meet in person with the Chinese ophthalmologist. And this was in Shenzhen, and this was in Guangzhou, in front of the artificial intelligence lab with the team, the very active team there. Also in Cairo, since 2016, among our guests, all our guests. And in 17, there was in Mansoura and in Cairo. And the Afro-Asian Council of Ophthalmology held their meeting in Cairo in 2018. And my hospital has the privilege to host twice a team of ophthalmological Chinese doctors, as we can see here with Professor, to the right side, Professor Wu, and to the left side, Professor Lin and Zhang. During March 2019, Professor Wu is giving his lecture on artificial intelligence, which was the theme of that meeting. Also, presenting a session with Professor Zhang and me. Professor Lin is giving his lecture. Professor Zhang also is giving his lecture, and at the gala dinner of the meeting, we had a nice honoring for their perfect lectures that enlightened the subject, difficult new subject of artificial intelligence. Social activities were a lot. We shared together all with other guests from all over the world. And our last face-to-face meeting was held in Ismailia, which is a city by the Suez Canal in Egypt, historic city. It was in December 2019, immediately after the closing down of the world after the pandemic. Now, my subject today is decision-making in management of recalcitrant keratitis. Keratitis can be somewhat difficult, and sometimes we face unclear situations. We need to have decisions. So I'm sharing with you some cases that were difficult and we could manage them. First, I will go with some cases of post-penetrating keratoplasty keratitis. This was a case of a boy, 10 years old. I did for him a penetrating keratoplasty in 1984. It was never rejected until I did for him a AACO and IOL when he developed cataract in 2018. To find rejections, and it was repeated over a year following this AACO surgery, and he takes treatment, he gets well, but next time more severe and more aggressive, until I reach it to this level. Marked vascularization, engorgement of those vessels. The vessel is really going here inside the wound and inside the graft, and there is marked destruction of the graft I'm very near from the pupillary area. This vessel should be closed immediately. And that's what I thought about. And the easiest way was to do subconjunctival bevacizumab for the case. And here is how nicely those vessels turned into ghost vessels, and the cornea has been quietened without any later rejections. This is a case 3 weeks after penetrating keratoplasty, and we can see here that there is infiltration around sutures. They are getting loose, and this infiltration does not look good at all. My decision, this is by high power, and my decision was immediate removal of these sutures and culture of the suture with the surrounding infiltration. It came to me that it is Aspergillus fumigatus, and by treatment we can see the case has been cured with good healing here in the wound. A similar case, and here the infiltration was near the limbus, and we can see here it's having aggressive vessels also. This is endangered. So I decided again to remove these sutures and culture them to prove again Aspergillus fumigatus. So treatment was given and the case was quietened. In alkali burn, we should never hesitate to use corticosteroids in the proper time, dose, and duration. We usually use the immediate and early management of chemical burn with copious irrigation and removal of any particles. But the next phase, our eyes are directed towards 4 important things: decreasing the inflammation, monitoring the intraocular pressure, and limiting the matrix degradation and promoting re-epithelialization of the cornea. Otherwise, we will lose this cornea into melting. There is an intense polymorph nuclear infiltration of the corneal stroma after any acute alkali burn. And this is a major source of proteolytic enzymes capable of dissolving corneal stromal collagen and ground substance. Corticosteroids are excellent inhibitors of polymorph nuclear function, and intensive topical steroids is recommended for the acute phase following chemical injuries. Then, after 2 weeks, when we control the condition, we can markedly reduce the dose because, of course, we all know corticosteroids, as much as they are beneficial, but they can cause inhibition of the wound healing and increasing the risk of infection. This was a case of a 10-year-old boy. He presented 2 months after acute alkali burn. And he was given a regimen of antibiotics, topical, cycloplegic, and unpreserved tears substitutes without any steroids. His eye was extremely angry with epithelial ulceration, as we can see here, and intracorneal hemorrhage, neovascularization, and angry, very angry eye. My decision was I should add immediate topical heavy steroids. Also, I added tetracycline to inhibit the polymorph nuclear induced collagenolysis, and I give also systemic vitamin C to promote collagen synthesis. And this is the case after 1 week. We can see that the epithelial defect has healed and the eye gets less angry and the intracorneal hemorrhage disappeared. Separative corneal inflammations sometimes need to be differentiated from each other because sometimes it is not easy. This case is from the literature, very nice photo, a very rare disease called herpetic necrotizing keratitis. It is a separative corneal inflammation, and it should be differentiated from fulminant bacterial, fungal, or acanthamoeba keratitis. Actually, I had a case very similar to this. It was referred to me on acyclovir. There was no history of previous epithelial herpes simplex, and there is no improvement on the acyclovir. So I decided to take a biopsy, and it proved to me Fusarium keratitis. So it's different diagnosis and needs different treatment. I started antifungal treatment to see that now we have amelioration of most of the infection at 4 weeks, more and more in 5 weeks, and totally healed in 7 weeks. The contrary, this case has been referred to me on antifungal based on multiple satellites. But actually, satellites should be one big lesion surrounded by small lesions, but not that they are side to side like this. There is also here a neovascularization intensive, and here there is ulceration with staining. If we look at the cornea, we will find that there is ground glass appearance of previous attacks of keratitis. And when we look at the patient history, proper history, and see the previous medication, there was repeated attacks of herpes simplex. And now we have herpetic keratitis and uveitis, herpetic keratouveitis. This patient was giving steroids and acyclovir topical and systemic to have at 1 week starting improvements, less infiltration and less ulceration and less angry eye. Now at 3 weeks, it's markedly improved, as we can see here, and to close and heal by scar totally after 5 weeks. There is a question that I observed during seeing our cases of hepatitis C, as we have really, it was endemic in Egypt, and before the invention of, or the discovery of the Sovaldi, we had a very bad endemic in our country, but now it is luckily controlled. I searched in the literature to find that there is a hepatitis C associated keratitis. There is association between the Mourad ulcer and the hepatitis C, between the peripheral ulcerative keratopathy called PUC, as we can see in this nice picture of Dr. Baratz et al., also between the hepatitis C and keratitis with all kinds of peripheral keratitis. What is the possible mechanism for this? It is postulated that it is antigenic mimicry, in which the host immunity against hepatitis C antigens cross-reacts with epitopically similar autoantigen in the patient. So immunoreactivity directed against the exogenous virus antigen are absorbed into the cornea. And why are they absorbed? Because the concentration of the hepatitis C virus RNA interior fluid can be higher than that in the plasma. So the exposure of the ocular surface to a relatively high viral antigen load is possible. Let me discuss this case with you. This case was in a patient who was admitted to the hospital for liver transplantation for advanced hepatitis C virus liver disease. And actually, 1 day after he was admitted, and while he is doing his required investigations, immunovasculitis big toe occurred, leading to gangrene in his big toe. So also he developed this keratitis. His labs came to show that there is decrease in complement 3 and more decrease in complement 4 and the cryoglobulinemia. And this means that we have an ongoing immunological reaction in the body in the form of this vasculitis in the big toe and the keratitis. The case improved very much on steroids in few days, just topical steroids, and it made me think whenever I see such cases with hepatitis C virus. The epithelium and the healing is a real problem. Epithelium will never grow over a surface like this, rough surface like this. So if we have something like this deposit and reaction over the cornea, it will stay as an ulcer for a long time. And if we invert the lid for this patient, we will find that it is vernal conjunctivitis. So this is a shield ulcer. And the shield ulcer should be curated here, remove all this rough surface and leave the cornea healthy to the epithelium to overcome. And that's what really I did. I curated all this and allowed the epithelium to heal, and it healed well. They are rare but serious complications of vernal keratoconjunctivitis. They may be unresponsive to standard medical therapy, and surgical debridement is a fast and effective procedure, yielding rapid healing of the ulcer, minimizing the complications such as infection. Of course, to have a proper management, we should have proper diagnosis. And diagnosis lies not only in the clinical picture, but the history is very important. And the history, we should check the patient's medication. Sometimes patients hide some drugs from you. He knows that if he tells you, you will never allow him to use it, and he is comfortable with it. So he hides it away. And that's exactly what happened in this patient. A teenager boy has irritation in his eye for a very long time, received many treatments, and his cornea developed, both eyes developed ulcers, and these ulcers were very recalcitrant, so he was grafted, some sort of graft. I don't know exactly what is the nature of this graft. It has been dissolved in parts, and remains are present in his both eyes. On everting the lids, I found that there is definite spring catarrh, irritating spring catarrh. And then I tested the sensation of the cornea to find that it is lost completely. So this is a neuroparalytic keratitis. And when we ask the patient properly and force him to say what he is taking, we found that he is on topical anesthetics for years. He once discovered accidentally that it cures him or let him feel comfortable from his irritation. So he started to buy it by himself and use it on regular basis for all these years, getting his cornea completely out of sensation. So first of all, we stopped this topical anesthesia. We should allow at least 6 months for the cornea to recover its sensation from this neuroparalytic keratitis. And this irritation from the spring catarrh should be treatment. So supratarsal triamcinolone injection was given, and it usually gives a marvelous results. Debridement is important for drug penetration. Let's go for the golden standard drug for fungal keratitis and see how is it effective with or without the epithelium. If the epithelium is debrided on a daily basis, we can use 0.15% concentration, giving a significant antifungal effect. But if it is the epithelium left intact, half of this concentration will be without any effect, and with this concentration, it will be much, much reduced. Let's see these three cases. We have masses here, and the epithelium, these masses are hindering the penetration of the drug. We must give space or a way or a channel to go through for the drug through the cornea. And actually, debridement allows you three things. First of all, remove good bulk of the infection so that it's more easier to treat. Second, it gives you material for the culture, and here it proved Aspergillus species. And then it allows good penetration of the drug so that you can get healing of the condition. This case, it was an overhanging mass, will never allow the drug to penetrate. So it was removed. This is immediately after removal, and it was cultured to prove Aspergillus niger. And this is after 2 weeks of treatment of antifungal with antifungal treatment, and here after 5 weeks nearly healed. This case was also referred on all kinds of microbial therapy without any effect. So I decided to remove this mess, or as much as I can, but astonishingly, it went out all together in one scratch. And this I sometimes see with the Candida species. And actually, the culture proved it is Candida. And on antifungal treatment, it has been healed at 3 weeks. Thank you very much. And I hope next time we can be either in China or in Egypt, and we share our scientific knowledge and social life together. Thank you very much.